I'd like to welcome everybody to today's presentation on alcohol and drug-related brain damage. I'm your host, Dr. Dawn-Elise Snipes. Today we're going to talk about a variety of disorders, including those that are induced by substance use, such as persisting amnesic disorder, psychotic disorder, mood disorder, sexual dysfunction, sleep disorder, and persisting dementia. In addition to some other brain traumas or brain issues that are caused by substance misuse, including FASD, chronic traumatic encephalopathy, and neurocognitive disorder. The prevalence of brain damage in people with substance use disorders is estimated to be between 30% and 80%. All right, so let that sink in. If you're working with somebody, even if their primary presenting issue is mental health, if they have a substance use disorder, there's a really strong likelihood that they've got some level of brain damage as a result. Now, can that heal? Possibly. Definitely can be stabilized in a lot of cases. These impairments can significantly impact symptoms and treatment outcomes. Physically, when we're working with somebody who is struggling with substance use issues and inflammation in the brain and systemic inflammation, they're likely going to have sleep problems, inflammation issues, pain. They can develop neuropathy and hormone and neurotransmitter imbalances. Interpersonally, if they're struggling with substance use disorders, they may have issues with self-efficacy and the ability to interpret nonverbals in other people, which strains relationships. Emotionally, they'll have probably dysregulation and potentially apathy. Cognitive deficits include difficulty with executive functioning, memory, and resultant treatment compliance. And then environmentally, some people with substance-related brain disorder end up needing assisted living due to physical or cognitive impairments. We do need to recognize that substance-induced brain disorders can have long-lasting and multifaceted effects on the people. Again, even if they're not presenting with that, if you know the person you are seeing is, let's say, a, quote, heavy drinker, then there's a chance, a better than average chance, that they've got some level of substance-related brain damage. Use of alcohol will cause systemic inflammation, causes inflammation in the gut, causes inflammation throughout the body, can cause brain inflammation over time, and potentially slow recovery from other issues. This has its own slide because a lot of us work with people who drink. And, I'm not saying that we need to have a goal for every person we work with to become abstinent. That's not realistic, and that's maybe not their choice. However, we do need to realize the impact that alcohol has. We also need to realize that heavy drinking is considered anything more than 1 drink a day for women and 2 drinks a day for men. And when we talk about a drink, we're not talking about a drink. We're talking about a drink. So we need to be cognizant of the fact that when people report they have some wine every evening, is it 5 ounces of wine or is it half a bottle? There's a difference there. And not to be judgmental, but we do need to pay attention to the fact that half a bottle is considered very heavy drinking and likely is contributing to systemic inflammation. Just go over some brain regions really quick because these are the brain regions that are negatively impacted by substances. And when we start looking at substance-induced brain disorders, we're going to see problems that correlate with the brain regions that are affected. The frontal lobe. Whenever I talk about executive functioning and wise mind, I talk about the prefrontal cortex and the frontal lobe. Motor control and movement, executive functioning, personality and social behavior, language and speech, emotion regulation and impulse control, and memory storage. So again, even if your person is not presenting with substance use issues, If they have them, we may start seeing some of these problems. If we're seeing them for anxiety, for anger, and they're drinking a lot, then they may continue to have emotional regulation and impulse control issues, speech and language issues, and executive functioning issues as a result of that alcohol use that's going on. The cerebellum, motor movements and coordination and balance, motor learning, and it contributes to speech and language processing. So the cerebellum is another area we don't talk about a lot, but when we consider motor movements, balance, and motor learning, the parietal lobe is involved in sensory integration and perception, being able to recognize what's going on, being able to smell, see, hear, integrate those senses that are coming in into something that our brain can interpret. Spatial awareness and navigation. A lot of people who have difficulty with their parietal lobe have difficulty with, have a higher risk of falls because they have difficulty knowing where they are in space because of sensory integration and proprioceptive issues, and have difficulty navigating in a particular space. Parietal lobe is also involved in mathematical reasoning and calculation, reading and writing, and visual attention and processing. So we do have some attention issues that come with damage to the parietal lobe. And then the limbic system we typically think of as the area that does all of the emotion regulation, and that's way oversimplified, but it is responsible in large part for some of the emotional regulation in addition to the frontal lobe, and memory formation and consolidation, and motivation and reward. When there is damage to the limbic system, the people we're working with are going to have problem with emotion regulation, memory formation, and motivation and reward. Does that sound like somebody with an addiction? Does to me after working with them for a quarter of a century. Recognizing that some of this stuff, some of these symptoms or behaviors we're seeing are not willful resistance. They may be the result of brain damage. We need to figure out how we can help the person mitigate that problem to the best of their ability. Drugs causing brain atrophy. We're just going to go through some of them real quick, and then we'll start going into each of the disorders. Neurodegeneration, brain damage, is due to neurotoxicity. So the brain actually becomes toxic and neurons start dying. Chronic inflammation, excitotoxicity, that means those stimulatory chemicals like glutamate are in too great of a supply, so it becomes basically too hot to handle, and we start losing neurons. And disruption of neurotransmitter systems. As we dysregulate, for example, the dopaminergic system, it also pulls with him, I don't know why I think dopamine is a him, pulls with it all of its buddies, serotonin, norepinephrine, GABA, glutamate, acetylcholine, and we start to see an altered neurotransmitter balance that is reliant on the presence of that substance, which is where we end up with substance dependence. Let's talk about alcohol. Alcohol is one of the most frequently abused drugs. Next to nicotine, you can argue, but generally alcohol is thought to be much more popular. Alcohol-induced neurotoxicity leads to oxidative stress, thiamine deficiency, excitotoxicity, and neuroinflammation. Now, oxidative stress is what happens when we have too much, basically gunk building up in our system, and our system can't get rid of it because of all this other stuff that's happening. There's excess gunk created. Antioxidant diets, anti-inflammatory lifestyles can be very helpful at reducing systemic inflammation and oxidative stress, which is good. But with alcohol, if the cause of the symptoms that we're seeing in that particular person is due to a thiamine deficiency, which is often the case in people who heavily drink alcohol, then we need to make sure that they are able to get emergency treatment. Chronic alcohol use is associated with brain shrinkage, particularly in the frontal and parietal lobes and the cerebellum. So all of these areas, motor coordination, speech, and emotional processing, all of these areas we're seeing shrinkage. This causes problems in executive functioning, impulse control, emotional regulation, coordination deficits, and dysarthria, which is difficulty actually articulating words. They can think of them and they can try to say them, but they start slurring their words. And we've all seen dysarthria in people who are intoxicated for certain. Stimulant use leads to dopamine neurotoxicity, again, neuroinflammation, oxidative stress, and excitotoxicity. Any of these drugs, you're taking in a toxin, basically. You're overwhelming the system, causing high alert. When our system is on high alert, that stress response is triggered. And over time, we're going to cause neuroinflammation, oxidative stress, and excitotoxicity. So that's kind of one of those things that's common to all of them. Stimulant use leads to reductions in the prefrontal cortex, limbic structures, that emotional processing and regulation, and basal ganglia, which is an area of our brain that's part of the limbic system that is important for movement. This causes problems with executive functioning, emotional blunting, depression, and motor impairments. In terms of opioids, we're talking about heroin, fentanyl, as well as prescription opioids. Use of these drugs slows the system. They're considered opioids, but they're also depressants. They slow the system, which can lead to hypoxia, not enough oxygen getting around the body, especially to the brain. We've talked in other videos about hypoxic brain injury, neuroinflammation, and glial cell dysfunction. There's atrophy in the frontal cortex, the hippocampus, and the cerebellum that all coordinate with cognitive impairment, problems with motor coordination, and again, executive functioning. We keep coming back to motor coordination and executive functioning. And remember, executive functioning is the ability to pay attention, to concentrate, to organize, to plan, to reason, all of those wise mind things that we need in able to be able to deal with life on life's terms and function from a fact-based reasoning point of view as opposed to an emotion-based reasoning point of view. Inhalants, we don't talk a lot about them, but inhalants are wicked on the brain. This can include toluene, nitrous oxide, solvents, and paint. Inhalants cause direct white matter toxicity, demyelination, and neuroinflammation. Demyelination, when the myelin sheaths are kind of like the insulation on electric cords that keep the signal going down the cord instead of, branching out or whatever. Demyelination means you're removing all of that insulation, if you will, which means that nerve signals don't transmit nearly as well, if at all. Problems because of that include atrophy in the frontal and temporal lobes and cerebellum, which leads to ataxia, which is a lack of coordination and balance, again with the dysarthria, memory impairment, executive functioning deficits, and an increased risk of dementia. And that's important. What we're talking about when I say increased risk of dementia, I mean actual progressive dementia later in life. Cannabis, especially high-dose chronic use cannabis, is associated with hippocampal and prefrontal cortex alterations related to endocannabinoid system dysregulation. When people are heavily using and chronically using cannabis, the system gets used to having that. So it reorganizes with the expectation that it's going to continue to have that. This leads to reductions in the orbitofrontal cortex, again, that frontal cortex area, and which plays a critical role in decision making, impulse control, emotion regulation, and reward processing. If you've been working with people with addictions, I want you to take a minute and think, based on the substances that they abused and the symptoms they had, can you see a correlation? Now, again, executive functioning deficits come with all of them, so it's hard to separate. And many people are polysubstance abusers, so they're going to have multiple symptoms that relate to the different drugs of abuse. But I think it is interesting, again, to recognize that as providers, in order to help people heal, we need to recognize that it's not just a will thing. It's not just a thought thing. It's not even just a behavior thing. It's a we need to heal the brain thing because there's been damage. And when people come into treatment, whether they get out of detox and they're in outpatient treatment, or they get out of detox and they're in residential, or maybe even they quit using 10 years ago and they're starting treatment. But remember, we talked before class about how use and repeated instances of the brain experiencing inflammation can actually lead to the development of chronic traumatic encephalopathy. So we may see somebody who got sober 10 years ago starting to have symptoms related to the brain damage that was caused during their use. So let's start talking about these disorders. Now, one of the ones that's been in the DSM for the longest is hallucinogen I can never say this one for some reason. Hallucinogen persisting perception disorder. People who've used hallucinogens like LSD may have flashbacks, echo phenomena, and other psychotic manifestations, which typically occur after drug-free periods and may persist for years. Okay, underscore years. You can be seeing somebody and they may not have had a hallucination for 2 or 3 years, and all of a sudden they have one. It's not something that happens like all the time, every day for years, which is one of the reasons it makes it so scary. And it's one of the reasons that people who've used hallucinogens are often ruled out of safety-sensitive positions. Symptoms include palinopsia, or seeing after images or trails behind moving objects, halos and auras, geometric patterns, floating or moving shapes. And I'm not talking about those floaties you see when your blood pressure gets too high. I'm talking about seeing shapes and things floating and moving. Color shifts, objects appearing like they're unusually bright or changing in hue right before your very eyes. Visual snow or grainy distortion, size and depth perception issues. Those are all different perception issues that happen as a result of hallucinogen use. Other symptoms include anxiety and panic attacks related to those persistent or episodic visual distortions. And when I say episodic, I mean it's something that has happened persistently and periodically, episodically, since they used the hallucinogen. They may have depersonalization and derealization, feeling detached from reality. Again, most of the time, it's very episodic. And difficulty concentrating due to visual disturbances. I have worked with some people who have persistent visual snow after using substances, and it does make it very hard to concentrate. If you're old enough to remember, back when we had the old, I guess it's called analog TV, and we had the rabbit ears that we had to adjust, otherwise the picture would be all snowy. And it was frustrating, but sometimes you could only get it so good, so you'd be watching your favorite show, but it would be really grainy and snowy. That's what life is like for these people all the time, and it can actually cause a headache. I mean, let's just call it what it is. We need to recognize and acknowledge what people are experiencing, and again, help them figure out What can I do when I'm having an episode to manage it? What is within my control? Delirium. Sudden onset of disturbance in attention and awareness or orientation, disturbances in cognition, memory, or perception. Generally, we only see delirium when somebody's withdrawing from or intoxicated by particular drugs. So if they're taking drugs or have taken drugs in the past, 2 weeks or something, being aware of this. Now, there are a few that we talked about before, a few drugs that are lipophilic, and they're stored in peripheral fat tissue. And when somebody loses weight, sometimes that drug is re-released in the body. So we may see episodes of protracted withdrawal where the person exhibits some signs of delirium as a result of that. It doesn't mean they used again. It means their body's excreting some again all of a sudden. I mentioned earlier a lot, chronic drug abuse can contribute to the development of chronic traumatic encephalopathy due to repeated excitotoxic insults, repeated inflammation of the brain, oxidative stress, and related vascular damage. When there's a lot of inflammation, it causes damage to the blood vessels that are in the brain. We know, think my father-in-law, when he gets upset, we can see that vein in his neck starting to pop out. And my mother-in-law is always like, remember your pressure. We know that when we get stressed out, when our blood pressure goes up, it puts a strain on our vessels. Same thing's true with those little tiny vessels in the brain. And a lot of these substances, either when they're being used or when somebody's detoxing from them, cause the blood pressure to go up and cause stress on those vessels in the brain. CTE is most commonly associated with repetitive external head trauma, getting hit in the face, boxers, repeated car accidents, soldiers, etc. But emerging research suggests that chronic substance abuse, particularly abuse of stimulants, inhalants, or alcohol, can lead to similar neurodegenerative changes, which can develop even years after the insults have stopped. Even years after the person has quit using, we may start to see the symptoms. The damage was done back then, and the plaques started being laid in the brain, if you will, or started forming in the brain. But a lot of times we don't see the symptoms for many, many years. And then at that point, the person is moving into the region of being diagnosable with dementia. Wernicke's encephalopathy occurs when a lack of thiamine, vitamin B1, leads to energy failure in the brain cells, causing neuroinflammation, excitotoxicity, and neuron death. This is caused by a lack of thiamine. The lack of thiamine can be due to chronic alcohol use disorder, definitely. It can also be due to malnutrition and starvation as seen in eating disorders, cancer, chronic infections, and post-bariatric surgery. There is no research that I've found yet on some of these new medications that are causing people to lose weight really, really rapidly, but I'd be interested in knowing what their thiamine levels are. We also see vitamin B1 deficiency in people with gastrointestinal disorders like celiac disease and Crohn's disease. These are autoimmune disorders that can get triggered, cause inflammation in the gut, and then the gut can't absorb that thiamine. We also see it in people who are undergoing dialysis, people who have hyperemesis. They throw up a lot. And generally hyperemesis, it can go along with chemo, but the time I most frequently see it, or unfortunately, is in women who are pregnant and they have really bad morning sickness. We do want to be alert to changes that we see in people who meet any of these criteria in order to prevent it developing into a big deal. And people with HIV and AIDS also have difficulty with thiamine absorption. Korsakoff syndrome. Now, Wernicke's encephalopathy is a syndrome that develops when you don't have enough thiamine. If that is left untreated, it moves into Korsakoff syndrome. This consists of two separate but related stages: Wernicke's encephalopathy, then Korsakoff syndrome. Not everyone has a clear case of Wernicke's encephalopathy before Korsakoff syndrome develops. This often goes very, very undiagnosed in anybody, with the exception of people with alcohol use disorders, because it is so wrongly only associated with alcohol use disorders. But we need to be more aware. We need to be more inclusive of the other disorders that can cause a significant thiamine deficiency. Korsakoff syndrome is diagnosed in about 1 in 8 people with alcohol use disorder. Think about how many people you've seen with alcohol use disorder or who would meet the criteria for alcohol use disorder. 1 in 8 of them have Korsakoff syndrome. It's already past Wernicke's encephalopathy. All right? So that's a problem. Korsakoff syndrome, however, is still much less common than other forms of alcohol-related brain damage, such as neurocognitive disorder, is what it's now called in the DSM-5-TR, used to be called alcoholic dementia. Going back to encephalopathy, because this is where we can catch it, this is where we can intervene. Symptoms include sudden disorientation, confusion, or mild memory loss, evidence of malnutrition, involuntary jerky eye movements or paralysis of the muscles that move the eyes, sudden poor balance or unsteadiness, staggering and stumbling, lack of coordination. And when I say sudden, I mean last Tuesday Jane was in your office and she was doing just fine. This Tuesday Jane's in your office and she sure is acting like she's drunk. She's sure acting with a lot of these symptoms. That is a clue. Obviously, we're going to ask her, have you had anything to drink or used any drugs? If she says no, we need to say, medical emergency. The involuntary eye movements, I've only seen this once, but I have seen it in one of my patients who was in group therapy with us, and all of a sudden her eyes rolled up into her head and she couldn't roll them back down. She was perfectly conscious. She was able to talk. She was able to communicate, but she could not roll her eyes back down. Clearly, we called 911. She went to the hospital and they got her on IV thiamine to try to start controlling this issue. If Wernicke's encephalopathy is suspected, immediate medical treatment is essential to prevent permanent brain damage. If it's not treated soon enough, Korsakoff syndrome gradually develops, which causes damage in several regions of the brain. Symptoms of Korsakoff syndrome include severe loss of short-term and day-to-day memory. You see people going from mild memory loss to all of a sudden it's just rapidly getting worse. Problems learning new information, including new routines, life skills. Inability to remember recent events. Gaps in long-term memory. Memory problems in Korsakoff syndrome may be severe, while other thinking and social skills are relatively unaffected. You're not going to see someone who has a complete deterioration of their ability to function. It mainly affects memory, short-term memory and some long-term memory, which can be really confusing for clinicians and for loved ones. What's going on with John? I told him this 5 minutes ago and he's forgetting. He must be ignoring me. No, maybe not. Maybe he has severe memory problems. An example, an individual may carry on a very coherent conversation with you, but moments later be unable to recall that conversation even took place or who they talked to. So if the nurse comes and talks to them and they have this conversation about their meds or what's going on, and they're very on point, 5 minutes later, they may have forgotten that conversation even existed. Those with Korsakoff syndrome may confabulate or make up information they can't remember. They're not lying, but may actually believe their invented explanations. Their brain notices this gap and it tries to fill it. If you've ever read your own work, and there are some of these memes out there online that have something, a saying that is terribly misspelled, but you read it with no problem. And then somebody says, go back and look at that. And you reread it and you realize there were all these spelling errors in it. Or you read work that you already wrote and again, terrible misspellings in it, but you don't see them because your brain knows what it thinks is supposed to be there. We see the same thing in Korsakoff syndrome. You ask them about something and their brain knows there's something that's supposed to be there. So it kind of fills in the gaps for them. And this isn't an intentional thing they're doing. It is not. And helping family members that are living with somebody with Korsakoff syndrome, this can be one of those issues that we really need to focus on. This is also true in residential treatment. Helping people who are clinicians who are working with people with Korsakoff syndrome understand that John may not be telling us what objectively happened, but in his mind, that's what happened because that's what his brain's telling him happened. So let's move on to more globally other types of alcohol-related brain damage. And I'm really drilling down on alcohol because it is the most frequently abused drug. And it is the one that is most frequently associated with developing chronic traumatic encephalopathy out of, stimulants, inhalants, and alcohol. Alcohol is the one that's most frequently abused out of those three. Most excessive drinkers do not meet the criteria for dependence. They may present in mental health clinics for treatment of a mood disorder. And I want you to realize, if you haven't looked at the DSM-5-TR criteria, that substance dependence and withdrawal are no longer mandatory criteria for diagnosis of a substance use disorder. You have to have a certain number of criteria, but dependence is not required. That's a huge change. That is a huge change because a lot of people used to say, well, I don't have an alcohol use disorder because I'm not dependent on it. I don't have withdrawal symptoms. Now that doesn't automatically grant them an exemption. About 21.7% of the adult population reported binge drinking and 6.3% reported heavy drinking within the last 30 days. That's a lot. Damage directly caused to the person by exposure to alcohol or other drugs include neurocognitive disorder. We used to call it alcohol-related dementia or inhalant-related dementia, but now it's just lumped under major neurocognitive disorder. Vascular dementia can be caused because damage to the blood vessels to the brain may prevent the brain from getting enough blood and oxygen and eventually cause systemic inflammation, neuroinflammation that leads to the development of plaques and the development of dementia, the progressive disorder. And fetal alcohol spectrum disorders. Even if the alcohol theoretically isn't directly impacting the adult, the little peanut is getting a really high dose of it, because what mom drinks kind of goes to the baby. It goes through the umbilical cord. So, baby's getting quite a little hit of whatever mom's taking. And so we can see fetal alcohol spectrum disorders even in people who don't use a lot, even in people who don't drink a lot. Alcohol-related brain damage is greatly undiagnosed. Post-mortem findings indicate that it affects 3 per 100 of the general adult population. So the next time you go to church or you go to Walmart and you're around 100 people, recognize that at least 3 of them have brain damage, alcohol-related brain damage. That's kind of a staggering statistic. Among those with alcoholism, this figure rises to as high as 1 in 3. So people who are heavy drinkers, as many as 30% of them have some level of alcohol-related brain damage. People with alcohol-related brain damage tend to be at least in their 40s or 50s. Alcohol-related brain damage is thought to cause more than 10% of cases of dementia in people under 65. So this is one way we can definitely reduce dementia. In contrast to dementia, most people with ARBD who receive good support and remain alcohol-free make a full or at least a partial recovery and will not experience a worsening of their condition as long as they don't go back to drinking. Individuals with alcohol use disorders, however, have a 3 times increased risk of all types of dementia. That's another one of those that is kind of scary. It's like, even if they stop drinking, they have kind of laid the groundwork because of that persistent neuroinflammation for however long, and that puts them at an increased risk of developing dementia. Drinking more than recommended limit for alcohol increases the person's risk of developing common types of dementia, such as Alzheimer's and vascular dementia. The recommended limits are now a maximum of 2 drinks per day for men and 1 drink per day for women. Although, if you looked at the report from the Surgeon General that just recently came out and the CDC, it indicates that there's possibly no level of alcohol consumption that is safe. And yes, before you freak out, I know that red wine, for example, has certain antioxidants in it that have been thought to be healthy. However, there are also other parts of red wine that are known to be very toxic and very inflammatory in nature. Repeated binge drinking is particularly harmful because when we binge drink, we're basically saturating and megadosing our system with this toxin. Increased risk of dementia is greatest at higher levels of alcohol consumption. People need to understand that they do not need to have alcohol use disorder or get drunk often to be at an increased risk of developing dementia. If they go out twice a month and, tie one on, they're going to have an increased risk of dementia. That's binge drinking. Regular drinking, even a little above recommended levels, increases risk. So let's go back to what we see on TV all the time. And I regularly comment to my husband, I'm like, these people are always drinking. 1 drink per day, 1 5-ounce drink of wine per day is the max that any female should have. 2 is the max any male should have. And when we're talking about this, we need to recognize that very, very rarely do people stop at 1 drink. Let's just be honest about it. Regular drinking over time causes damage to nerve cells, neurochemical changes in the brain, and shrinkage of brain tissue. Now, the beauty of this is that if we can help people start adopting a healthy anti-inflammatory lifestyle, where we're reducing stress on the body by having regulated circadian rhythms, by getting regular sleep, by eating a healthy diet, drinking water, not drinking alcohol, and doing things that are engaging for our brain, cognitive stimulation, we actually can create an environment that is promoting neurodegeneration. We're promoting the regeneration of some of those neurons. We're promoting the healing of the brain. We're promoting the rebalancing and rewiring, recalibrating, whatever you want to call it, of all those hormones and neurotransmitters. So while some brain damage may be permanent, just like after somebody has a stroke and maybe when they first come to, they can't move the whole right side of their body, well, eventually they may be able to do that again. Not as well as they did before, but really well enough. So we may not be able to fix completely what's gone on in that brain, but the brain wants to survive and the brain develops workarounds in the right conditions. We need to help people develop those right conditions so the brain can start healing itself. Regular drinking also causes intestinal damage, which causes poor nutrient absorption. We've talked about this so many times. When you eat crap, you feel like crap. Well, even if you're eating well, if your body can't absorb those nutrients and make those hormones and neurotransmitters, you're still going to feel like crap. Regular drinking causes poor handling of thiamine, damaged blood vessels, high blood pressure, increased risk of heart attack and strokes, increased risk of dementia, and often ongoing sleep issues. They found that compared to all the other drugs, people who have been abusing or heavily using alcohol tend to have a much longer period of persistence of sleep disorders. So that's another interesting thing. If you're working with somebody who is drinking or who has stopped drinking, we do need to really talk with them about their sleep and their circadian rhythms. I can't emphasize enough how important that is for their overall recovery from whatever they're presenting for, anxiety, depression, addiction, whatever, in order to help rebalance those hormones, rebalance those neurotransmitters, and reduce systemic inflammation. Symptoms of ARBD largely reflect the areas in the person's brain that are damaged. Oftentimes, depending on the level of alcohol-related brain damage, it's a spectrum. Poor planning and organizational skills, problems with decision-making, judgment, and risk assessment, problems with impulsivity, emotion regulation, attention, slowed reasoning, and just like somebody who has slowed cognitive processing, as we get older, we also may see slowed cognitive processing in people who have alcohol-related brain damage, which means that in treatment, especially if they're in group treatment, we may need to slow things down quite a bit so they can keep up. Or we may need to have people that have cognitive processing issues in a different group that can go a little bit slower until their brain heals. It doesn't mean that they're not intelligent. It means it takes their brain a minute longer to put things together than it does for people who don't have that problem. Unlike Korsakoff syndrome, not everyone with neurocognitive disorder or alcohol-related brain damage has a loss of day-to-day memory. People must have stopped drinking for several weeks in order to enable the symptoms of alcohol intoxication and withdrawal to resolve before they can be diagnosed as having alcohol-related brain damage. We need to get the alcohol out of the system and have the system sort of starting to reset itself before we can really determine anything. And remember, we talk about post-acute withdrawal, and depending on how long the person's been drinking, that may be longer or shorter. Then the person needs a full physical examination, including full blood panel, a detailed history from the person and somebody who knows them well, if possible, that includes how their symptoms started and affected their life, the person's history of alcohol use, tests of the person's mental abilities, their memory, their thinking, their problem solving, and tests for depression. A brain scan may also be required to rule out other possible causes of symptoms, including a stroke, a brain bleed, a tumor. And the brain scan can show changes such as shrinking of the cerebellum at the back of the brain, which supports a diagnosis of ARBD rather than dementia. ARBD should be diagnosed if the person has impaired memory, thinking, or reasoning, which is bad enough to affect daily life, and a recent history of several years of alcohol misuse. And, of course, they've been referred to their physician for a full neurocognitive workup. Either way, they need to be referred to their physician. If it's dementia, we need to get in there because there's a lot of stuff we can do to slow the progression of dementia. If it's ARBD that's non-progressive, then okay, that's fine. We still need to get in there and help the person develop a healthy, anti-inflammatory, anti-alcohol-oriented diet. Other physiological causes that can mimic ARBD include stroke, a brain bleed, a tumor, chronic fatigue syndrome, lupus, hypothyroid, medication side effects, especially benzos, and dementia, Alzheimer's, or Parkinson's disease. None of these issues are things to ignore. So we definitely need to refer them for imaging as determined by their provider. As in terms of treatment, there's a good chance of stabilization or improvement if the person is, of course, we're talking here specifically about alcohol-related brain disorder, if the person's given high doses of thiamine via IV. Okay, this is something they got to do in the hospital. It's not something they can just go to Walmart and get some thiamine pills. Don't do that. Don't do that. And they have to remain free from alcohol and adopt a healthy diet and anti-inflammatory lifestyle. Brain scans show that with abstinence, some of the damage caused by the excessive drinking can be reversed. I know I've said that already 2 or 3 times, but I don't want people to feel hopeless. I want them to recognize there is a lot that is within their power to control. There's a lot they can do to create an environment that allows their brain to heal. There's also a lot they can do if they get angry and pessimistic and stressed out that is going to work against them and contribute to more inflammation. So we need to help them make a decision about what they're going to do, about their behaviors, about their reactions, about their life in order to move toward what they see as their rich and meaningful life. Vascular dementia is caused when blood supply to the brain is interrupted. In terms of stroke, during the second stage of alcohol withdrawal, 24 to 72 hours after their last drink, people experience a spike in their blood pressure, increased body temperature, unusual heart rate, and confusion. This is common. This is why you need to be under medical supervision during alcohol detoxification, because if your blood pressure goes too high, you can stroke out. There can be vein collapse in people who are IV drug users, which can cause a stroke. And stimulant use in and of itself is going to increase blood pressure and can cause a stroke. Bradycardia, a really slow heart rate, can be caused by severe hypothyroid, opioid overdose, heavy alcohol use, or alcohol poisoning. And this is before your blood pressure goes way up. This is when you're in that kind of relaxed state. And we do want to be cognizant that when the heart rate slows too much, that the brain is not getting the oxygen that it needs. The most common cognitive symptoms of vascular dementia are problems with planning or organizing, decision-making, or problem-solving, difficulty following a series of steps like cooking a meal, slower cognitive processing, and problems with concentration, including short periods of sudden confusion. A person in the early stages of vascular dementia may also have difficulties with memory, language, and visuospatial skills. If we notice the person is having cognitive difficulties, we need to refer to a neurologist. That's just kind of common sense. But many people who use substances, even recreationally, may experience strokes or mini strokes while under the influence and not realize it, especially if we're talking about opioids that slow the heart rate too much, if we're talking about stimulants that spike the blood pressure, or if we're talking about alcohol that slows the heart rate at first and then spikes the blood pressure on the way out. The combination of high blood pressure plus alcohol or stimulant use greatly increases the chance of a stroke. As clinicians, we must be aware of the symptoms of dementia, differentiate it from intoxication, encourage people to seek immediate medical assistance, and be additionally attentive if a patient reports self-detoxing, especially from alcohol. I strongly discourage my patients from doing that because it can be so problematic. I'm like, at least go to your doctor, let them know what's going on so they can advise you what to do. But that's not one of those things I can force somebody to go to detox for. And finally, fetal alcohol spectrum disorders are caused by fetal alcohol to exposure to alcohol. It's along a spectrum, though. And a lot of times people think of FASD as a child that has these facial features or intelligence issues. That's not always true. The facial features are not always present and tend to disappear with age. So your adults that have fetal alcohol spectrum disorders tend to not look any different than the general population. And their intellect may or may not be impaired, depending on where they are on the spectrum. People with fetal alcohol spectrum disorders have many neurobehavioral problems, which produce profound problems with accurately processing information and relating to the world around them. 90% of individuals aged 12 and older who have frequent contact with law enforcement have a fetal alcohol spectrum disorder. One of the things with people with FASDs is they are very gullible a lot of times. They are very easily manipulated. They have difficulty anticipating consequences. So a lot of times a person with an FASD, what we'll see on their criminal record is the same charge over and over and over again. They don't escalate. They don't switch up. It's sort of the same charge. And that's not typical in non-FASD offenders. Youths with FASD are 19 times more likely to be incarcerated than youths without FASD in a given year. When we're talking about FASD, I like this chart because I like charts, but they can have a chronological age. Their birthday, they're 18 years old. Physically, their maturity, they're 18 years old. Developmental level of functioning, 9. Daily living skills, they're at about the age of an 11-year-old. Expressive language, 23 years old. So they may be able to talk with the grown-ups really well and carry on a conversation talking about things that you're thinking, wow, this person's brilliant. Receptive language, 7. So they're talking this big talk and talking about all this stuff, but when you talk to them, they don't understand much of it. So they'll talk about a lot of stuff and it's not a give and take conversation because when you try to respond to them, they don't process it very well. So they seem sort of oblivious to what other people say to them. Their artistic ability or other strengths may be, again, far advanced, maybe a 29-year-old. Their ability to decode when they read and figure out what they're reading and understand it is at about 16, and time and money concepts may be at about an 8-year-old. So this is not an uncommon profile of someone with a moderate fetal alcohol spectrum issue. Diagnostic features for FASDs are similar to the adult with alcohol-related brain damage because the same areas of the brain are damaged in the fetus when it is exposed to those insults, to those excitotoxic and neuroinflammatory insults from mom's alcohol consumption. It causes damage in those areas of the brain. For clients with FASDs, they may have problems with cause and effect relationships and impulse control. They may have problems with time management, the ability to generalize information, problems with understanding concepts and abstract thought, and perseverative behavior. Perseveration is commonly described and thought of as some form of repetitive behavior, like tapping their toes or drumming their fingers or knocking or pacing or whatever. It can also manifest as a particularly rigid way of looking at things and an absolute refusal to let go of an idea, which can border potentially on fanaticism. They often, when they're having perseveratory thoughts, may refuse to consider any other explanation. This is what I believe, this is the way it is, and you can't tell me otherwise. They have problems in all areas of processing information, particularly auditory. They do better when it's written. Remember on that other chart, the receptive language was very low, but the reading was actually a little bit higher. So writing things down can be very helpful. They may have problems with short-term memory, difficulty anticipating consequences, good expression but poor comprehension, already kind of covered that, and good at reading but poor at writing, which is interesting. Their fine motor skills may be problematic. People with FASDs will likely not benefit from standard treatments requiring conformance, motivation, and follow-through on multiple tasks. You're going to have to break it down, have them write out their own weekly goals, and remind them. Remember, they're having difficulty with memory that needs to be that we need to account for and mitigate. They have difficulty accurately anticipating consequences and repeatedly make the same mistake. It almost seems like they're, to use a phrase, shooting themselves in the foot. And we can see this a lot in addiction when people just repeatedly make the same mistake and relapse. I had one client that did that a bunch of times. It's just, we could see it like plain as day that he was getting to relapse, and it was always the same situation, always the same, clockwork, same situation. But every time it happened, he was befuddled that it happened. He couldn't understand where that came from. They may be unable to demonstrate remorse and get incorrectly labeled as antisocial. And it's not that they don't care. It's just they don't know how to demonstrate it. They don't know how to communicate it as well. And they have difficulty recognizing and reading other people's nonverbals. So they may not realize when they hurt somebody's feelings or offended somebody because they're not perceiving that person's nonverbals accurately. They do have a right to specialized treatment and accommodations, and they may or may not have addiction issues themselves. They often see themselves each time as making a single mistake, unable to see the connection with past behaviors. They're easily manipulated and often take the fall for other people. They often have gaps in their personal history account, including important facts. And they may, like others that have gaps in their memory, tend to confabulate. They tend to be quite impulsive and comedic. That's one of the strategies they've learned to survive with their current strengths as well as their current deficits, oftentimes is leave them laughing. They may not follow through with appointments due to inability to remember the appointment or figure out how to get there, not a lack of interest or motivation. Now, I know that was just a brief rundown on fetal alcohol spectrum disorders. I do have other videos on FASD on the YouTube channel that go into much more depth, but I do think it's important for us to recognize that the majority of people in correctional facilities and the majority of people that are in substance use facilities have a high likelihood of having some level of FASD, because it's likely, not for certain, but it's definitely not uncommon that their birth parent was abusing a substance and likely alcohol. And their birth parent may have been born to someone who was using alcohol as well. So we may see multiple generations of FASD in a particular family. Mental health clinicians are likely to see clients who present with depression or anxiety who are misusing or excessively using substances. And I use that term pretty broadly. Cannabis, stimulants, alcohol, ARBD, alcohol-related brain damage, can be caused by the use of the substance increasing blood pressure, causing a stroke, slowing the heart rate, or collapsing the veins, or withdrawal, particularly from alcohol. Heavy use is defined as more than 1 drink a day for women or 2 drinks a day for men. Many clients with alcohol-related brain damage are not alcohol dependent. They are not what we would typically classify in the general population as alcoholics. We need to recognize that and how dangerous alcohol actually can be. FASD is a brain damage caused by fetal exposure to alcohol. Those with a fetal alcohol spectrum disorder experience deficits in interpersonal and executive functioning, which may make it difficult to comply with traditional treatment. they have difficulty following the rules, following schedules, interpreting, and a lot of times even functioning within especially a residential environment in which they may be made the scapegoat or manipulated by other people who are in the program. Special approaches are required for working with persons with FASD. And finally, remember that these repeated excitotoxic neuroinflammatory events can make the person much more susceptible, much more likely to develop dementia later in life. So if you're working with somebody who at some point in their life was a heavy drinker, paying attention for early signs of dementia. The earlier we intervene, the better their prognosis is for slowing the progression of the disease. Are there any questions? I do not currently have any videos on transcranial magnetic stimulation. Come on, you want to say hi to everybody? All right. Boo says hi, everybody. Alrighty. Well, it looks like I've answered most of these questions. So that is always wonderful. Please remember that you can find additional information by going to docsnipes.com/clones. Additionally, at allceus.com, I offer the program I have is about 400 hours, which covers, and then some, the 270 plus hours of addiction-specific education required to become an addiction counselor in most states. There are a couple states that require you to go to a specific university program, but most states allow you to get your training through a NAADAC-approved provider like all CEUs. So if you know anybody who's interested in studying to become an addiction counselor, have them check out allceus.com.